Assalamu alaikum. It's my pleasure this morning to chair and share the first session in this Congress with my colleagues, Dr. Hanan al-Rais from Saudi Arabia and Dr. Ola al-Hajjawi from Jordan. This first session will be about systemic lupus erythematosus. We have 4 speakers in different aspects of this field. The first speaker will be Dr. Marwan Adwan. Dr. Marwan is a consultant rheumatologist and head of rheumatology division at the University of Jordan. He is the chairman of the scientific committee at the Jordanian Society of Rheumatology. His area of interest is connective tissue disease. His medical degree from the University of Dundee in the United Kingdom. He also went on to do his residency training in Manchester, and subsequently his rheumatology training was in London. He is a member of the Royal College of Physicians of Ireland, and he published several articles in peer-reviewed journals. Dr. Adwan is on the editorial board of the International Journal of Rheumatic Disease and a peer reviewer for several international journals. Dr. Marwan, the stand for you.
Thank you, Dr. Badia, for this nice introduction. I'd like to start this conference by talking about lupus in the Arab world. As we all know, lupus exhibits different phenotypic expression and antibody profile and severity in different ethnic groups, and Arabs are no exception to this fact. For example, in blacks, lupus is more common and more severe, and they tend to display autoantibodies such as Smith and RNP. Chinese, on the other hand, have a higher incidence of autoimmune hemolytic anemia, and they have anti-Rho antibody. Whereas Latin Americans, oral ulcers tend to be commoner than in other populations, as well as myositis. Europeans, surprisingly, have a high incidence of vascular thrombosis and increased frequency of anti-double-stranded DNA. So what about Arabs? What do we know about Arabs? As we all know, the Arab world is bordered by the 3 continents of the old world. It's bordered to the north by the Mediterranean Sea. Mediterranean in Latin means the middle of the earth. So the Arab world is really the center of the world. And throughout history, it has been the trading routes between East and West, as well as areas of conflict. And this has affected the demographic structure of the Arab world throughout history. So, with this in mind, we ask these questions. Is lupus in Arabs different from lupus in the rest of the world? Is it less or more common? Is it more severe or less severe? And is it the same among all Arabs, or is it different from one Arabic population to another? Unfortunately, there is very little prospective multicenter studies from the Arab world on these issues. We don't know the exact incidence and prevalence of lupus, as there is lack of national registers. To try and tackle these questions, we at our department undertook a systematic review, and we looked at most observational studies describing the clinical and serologic features of lupus in the Arab world. To minimize random error inherent in most small studies, we included studies of 50 participants or more. We also excluded clinical trials, articles reporting in children. We also excluded articles dealing with just one aspect of lupus, like skin or kidney or pulmonary. And I apologize to those of you who published on one aspect of lupus and I didn't include their studies. We merged the means of the clinical manifestations as well as the immunological manifestations of the various studies and came up with a weighted mean for each clinical manifestation to see the incidence or the prevalence of these manifestations in the Arab world as a whole. We've retrieved 22 studies from 11 Arab countries, and as you can see, the studies span about 3 decades from 1988 to 2016. Most of these studies, or all of these studies, were retrospective. There were some cross-sectional and case control studies. Most of the studies came from Saudi Arabia. There were 8 studies from Saudi Arabia, 3 studies from Tunisia, 2 studies from Jordan, 2 from Kuwait, and the other 7 countries had or contributed just 1 study each. And this is the number of patients from each study. Saudi Arabia contributed just under 1,300, under 1,000 from Tunisia, and the rest of the Arab world contributed just under 1,000. So Tunisia alone contributed to the rest of the other countries combined, okay, and Saudi Arabia more. I put this study because this paper came out. As you can see, I was surprised when I saw Egypt contributing just 59 patients. Egypt is the largest Arab country, contributing just 59 patients. And I was disappointed as well as surprised. But to abolish my surprise, a paper came out after we published our paper from Egypt by Mahmoud et al., including 770 patients. So I have not included this in our systematic review, but will put the figures of this study because this is a more representative paper of Egypt than the one I've included. So this is the paper. We've retrieved just over 3,000 patients. Our pooled mean age was around 29, and the range was 19 to 35. There were around 90% females and around just under 11% males, and the female to male ratio was 8.34 to 1. There was a family history of lupus in around 8.3%. So the mean age of disease onset was the same almost in all countries. The average was 28.9. Now, these colors will come out throughout the presentation. The blue is individual countries, the green is the grand mean we've come up with, and the crimson color is based on the Eurolupus study. These are the figures from the Eurolupus study, a study of 1,000 patients on European patients. So our mean was nearly the same as the Eurolupus mean. So we're not different in the age of onset to the European patients. The gender distribution, the female percentage varied from 75% in Yemen to 98% in Iraq. Now, before I proceed, I must stress, I want you to keep this in mind. The study from Egypt in this paper and the study from Iraq are very small papers based on 59 and 50 patients respectively. So bear this in mind. If you see a big difference from Iraq or from Egypt, with all respect to those 2 countries, it's just based on two small populations. Okay, so the red figure above Egypt is the figure from the last paper, which is based on 770 patients. Okay, so the female distribution was on average around 89%. Now, there aren't many prevalence studies. I've managed to find 4 from Iraq, Saudi Arabia, United Arab Emirates, and a study from US, from Michigan, on Chaldean Arabs. And the prevalence ranged from 19 to about 100 per 100,000. Incidence is even worse. There is very little incidence studies, just 2 I've managed, the Michigan study on Chaldean Arabs and the study from the United Arab Emirates. And the age standardized incidence ratio was 7.6 and 8.6 per 100,000 respectively in those two studies. So now I'll talk about, this is a very busy table, but you can tell from the table that number one, not all manifestations are reported by all studies, and there is a heterogeneity of figures between different countries. For example, look at mallar rash, for example, number 4. In Egypt, it's 91%, in Jordan, 49%, okay? And it's a big, huge gap between the two different countries. Now, these are the figures we've come up with after pooling the data. As you can see, arthritis or arthralgia were the commonest manifestations, followed by anemia, fatigue, mallar rash, renal manifestations, hemolytic anemia, photosensitivity, and so on. Okay, this is the trend of the clinical manifestations from the pooled studies from all Arab countries. Now, I want you to see these manifestations in individual countries. Now, in Tunis, for example, fever is very, very rare, affecting around 2% of the patients reported. And this is two large studies from Tunis, around just under 1,000 patients. Okay, and the average was about just under 44%, and this is slightly lower than the Eurolupus cohort of 52%. Mallar rash is equally heterogeneous, ranged from 35 to around 91% in the small Egypt study, but the larger Egyptian study showed a figure of 58.3%. The average, in fact, I must stress that this average is probably will not have been affected if I removed Egypt, because it's a small study, and when we pulled the mean, the small number of patients will affect the mean very slightly, okay? And equally, the means of the large Egyptian study are almost equal to our average. So if I add it, probably will have changed very little. Discoid rash. I was surprised because discoid rash, I worked in the UK, and discoid rash was very common in the black patients. I was surprised to see that it's very rare in Sudan, okay? And it's quite common in Lebanon and Egypt. However, the large Egyptian study showed a very low incidence of discoid rash. I'm sure Dr. Elgar will probably answer your questions about this from his experience. The average was 12.7%. Photosensitivity was quite rare in Lebanon, 16%, and reached to about 63% in Tunisia, and the proper figure from Egypt was around 35%, average 45%. Alopecia, rare in Tunisia, 33%, very common in the Arab Emirates, in Yemen, and in Kuwait. The average was about 41.5%. The Eurolupus cohort did not report alopecia to compare it with. Raynaud's was only reported in 4 studies, and it ranged from 3 to 19%. The average was 34. No, sorry, this is the wrong color I've put in this slide, but the European Raynaud's was very high, 34%. So we have a much less Raynaud than in the European cohort. Oral ulcers ranged from around 12% to 56%, and the average was 29%. Now, even the larger Egyptian study showed a much higher incidence of oral ulcers than the rest of the Arab world and than in Europe. Oral ulcers are commoner in the Arab world than in Europe, almost twice or 1.5 times. Arthritis, average 81%, more or less the same all over the Arab world, but the Egyptian study, the large Egyptian study, showed a very high incidence of arthritis of 80%, more common or the same as Europe, okay, and it's equal to the average. So arthritis is almost the same as Europe. Serositis, including pericarditis, peritonitis, or pleuritis, ranged from 10% to around 47%. The average was 35%, the same as the European cohort. Renal manifestations, on the other hand, are quite common. The mean was 50%, and this is much higher, significantly much higher than in Europe. And the Egyptian study showed an even higher incidence of almost 68%. 2/3 of patients from Egypt have renal manifestations or nephritis. Neuropsychiatric, the same as the European cohort, exactly the same, 27%. And this is the subdivisions of neuropsychiatric lupus. Headache was the commonest, followed by psychosis, seizures, and strokes. The other manifestations were very, very rarely reported. Cardiac manifestations, apart from pericarditis, a mean of 14%. Okay, the Iraqi study, again, remember 32%, but it's a very small study of 50 patients. Pulmonary manifestations, apart from pleuritis, 15% mean, and this is twice that of the European study. Antiphospholipid syndrome, not just APS antibodies, but the syndrome, 13.5%. No report from the Eurolupus study. Thrombosis was 8.3%, and this is significantly lower than that from Europe. Thrombocytopenia, 19.7%, again, much lower. Well, it's not much lower, sorry, slightly lower than Europe. Leukopenia, 41.4%. No leukopenia reported from, so I was surprised from the Eurolupus cohort. So I didn't include it. Autoimmune hemolytic anemia. Now, we need to look at this figure with caution, okay? Why? Because autoimmune hemolytic anemia generally, in most studies, is very low in the Arab world, okay? Almost the same, slightly higher than Europe. But the study from Tunisia had a very large incidence of hemolytic anemia, okay? And that's why the average was skewed considerably to 45%. If we exclude the Tunisian study, I don't know why Tunisians have a very high, I have no explanation. Perhaps it's a demographic structure or ethnic structure. Maybe the Tunisian colleagues can answer this question for you. But generally it's low in the Arab world, but high in Tunisia. The pooled autoantibodies, as we can see, ANA was in the majority of patients, double-stranded DNA, 74%. This is actually lower than European. The Europeans are around 78%. Rho and La around 50%, okay? Now, this is the ANA in individual country, more or less the same. Apart from Saudi, 77% lower ANA, but otherwise it's averaged around 97%. Double-stranded DNA, 74% average, but there was some discrepancy between different countries, ranged from 46% to around 91%. Rheumatoid factor, more than the European study, 23%, almost a quarter of patients had a positive rheumatoid factor. RNP, high RNP. Okay, it was low in Saudi, 7.8%, low in Kuwait, but from the other three countries that reported on RNP, Oman, Tunisia, and UAE, it was very high and higher than the European studies. Rho, again, Rho is almost half patients had a positive Rho compared to a quarter of patients in Europe. La, 29% compared to 19% in Europe. Again, Saudi and Kuwait have a lower incidence of Rho, La, RNP. So ENA panel seems to be lower in Saudis than the other Arab populations. Smith, again, lower in Kuwait and in Saudi, high in the rest of the Arab world, higher than Europe. Lupus anticoagulant, 17%, slightly higher than Europe. And the anticardiolipin antibody. Now, the Eurolupus study reported on IgG and IgM, whereas most Arab countries reported on the combined anticardiolipin antibody. So I've put the two from the European study. Ours was 47.8%. The IgG in Europe was 24%. And when I added the IgG and IgM, they were 37%. But that doesn't mean, you cannot compare the added IgG and IgM to the mean in Arabs, because in the Arabs it could have been either IgG or IgM or both, whereas these are the two together. Mortality, also you need to take this graph with caution, because the studies didn't report on 5 or 10 or 20-year mortality, but reported the mortality throughout the study period. Okay, this is the mortality throughout the study period, ranged from 1% in Kuwait to around 15% in Tunisia and in Saudi. Again, these are hospital mortality rates. They do not reflect the actual mortality of lupus. They are affected by referral bias, by severity of disease that patients, that doctors see in hospital and in tertiary centers. So do approach this graph with caution, please. These are the causes of mortality that were reported in the studies. Infection, active lupus, and kidney involvement were the commonest, and this is the same as in most studies. So, the commonest clinical manifestations in Arabs are arthritis, anemia, fatigue, malar rash, and renal manifestations in descending order. Okay? And this is similar to Europe and similar to a study called the Gladel study from South America. Now, these manifestations are no different between Arabs and Europeans: photosensitivity, serositis, neuropsychiatric manifestations, and thrombocytopenia. These are less frequent in Arabs than in Europeans: fever, malar rash, Raynaud's, arthritis, thrombosis, and myositis. And these are more common in the Arabic studies: lymphadenopathy, discoid rash, oral ulcers, renal involvement, pulmonary involvement, and I put a query near hemolytic anemia because it was skewed by the Tunisian study. Regarding antibodies, there was no difference between Arabs and the European study in ANA. Other antibodies, double-stranded DNA was actually lower in Arabs than Europeans, but the rest of the other autoantibodies were more common in Arabs than in Europe. Now, the limitations of our study, as well as the original studies, is most or all studies are hospital-based, so there is an element of referral bias. All of these studies are observational. Small number of cases in most studies, apart from one study from Saudi and one study from Tunisia. There is missing data in a lot of studies. And we didn't get studies from all the Arab world. There was no studies from Syria, for example, or from Morocco. Finally, I thought there is an element of heterogeneity among Arab people that could probably account, we combined apples with oranges probably here, but that's the best we can do. So what can we sum up lupus in Arabs as? It can be summed as in three words. It's common, it's serious, and it's underreported. So there are many questions that need to be answered. We need multi-center large studies, epidemiologic studies. Perhaps there could be a multinational operation, and perhaps we could form an ARA lupus like the Eurolupus studies. And thank you all very much.
Thank you, Dr. Marwan. There is 2 minutes for 2 questions. تفضل دكتور.
خالد المنتصر, Libya. Thank you, Dr. Marwan, for this nice presentation, which showed more or less the different.
This is a gentleman from Tunisia, so he's probably going to answer a question.
No, I'm from Libya. Libya.
Libya.
You showed maybe the difference among lupus in different Arabic countries. We Arabs, we have the same language and more or less the same religion, but from anthropological point of view, we are completely different groups. In North Africa, there are, for example, 50% of the inhabitants Berbers, Barabara, which from genetical point of view have nothing to do with the Gulf countries or Saudi Arabia or Absolutely. Even this region. We have in North Africa more people from South European origins, Greeks, Italians, Spains. We are Arabs, but from genetical point of view and maybe from microbiomal point of view, we are in a way very different. It shouldn't surprise us that these differences exist. Yes. Thank you.
Thank you very much. I did actually see we are combining apples with oranges, and I did look around this issue, and I found that Tunisia has a very large element of Berbers, and this may have affected the figures in my study, but I wanted to leave this for the Tunisians to comment on this rather than myself.
I think we don't have more time. Thank you, Dr. Marwan.
Thank you.
Thank you.